Anterior pituitary disease, adenohypophysis disease. Department of Endocrinology and Metabolism, West China Hospital, Sichuan University. Colon. The pituitary gland is located within the cella turcica ventral to the diaphragm cella. The hypothalamus, pituitary complex, is the master gland. It orchestrates the regulatory functions of multiple other endocrine glands. Vascular and neural connections between the hypothalamus and pituitary. The hypothalamic nuclei produce hormones that traverse the portal system and impinge on anterior pituitary cells to regulate pituitary hormone secretion. Posterior pituitary hormones are derived from direct neural extensions. Hypothalamus pituitary hormones. Two major groups of hormones secreted, inhibiting and releasing. Hypothalamic hormone target cell hormone. GHRH somatotrope, plus, GH. Somatostatin somatotrope, GH. Thyrotrope, TSH. Dopamine lactotrope, PRL. TRH thyrotrope, plus, TSH. Lactotrope, plus, PRL. GnRH gonadotrope, plus, FSH. Gonadotrope, plus, LH. CRH corticotrope, plus, ACTH. Hypothalamus pituitary hormones feedback regulation. Hormonal feedback regulation. Autonomous secretion of trophic H, or primary failure of target endo organ. High, normal, range. Trophic hormone level, normal. Autonomous secretion of target endo organ. Trophic H failure, low, low. Normal, high. Target gland hormone level. Case study 38, E2FSH/LH, E2. Disorders of anterior pituitary disease. Anterior pituitary diseases can be divided into three major types of conditions. 1. Hormone overproduction excess, hyperfunction disorder. 2. Hormone underproduction deficiency, hypofunction disorder. 3. Altered tissue response to hormone resistance. 1. Anterior pituitary hyperfunction disorders. What happens if too much prolactin secretion? Prolactin secreting adenomas. GH cell adenoma. ACTH secreting tumors. TSH secreting tumors. 2. Anterior pituitary hypofunction disorders. Most examples of hormone deficiency states can be attributed to anterior pituitary destruction caused by surgery, tumor infiltration, infarction, inflammation, infection, autoimmunity, hemorrhage, genetic abnormalities. 3. Hormone resistance syndrome. Glucocorticoid resistance. What happens if generalized GC resistance? Approach to the patients with suspected pituitary disease. Diagnosis of pituitary disease. Suggestion of pituitary disease. Symptoms, signs, others. H. Measurement and endo test. Functional evaluating of pituitary. G. Hyper/hypofunction. No. Yes. Localization of the lesion. Etiology study. Cytologic studies as semen analysis for hypogonadism/or infertility, fine needle. Biopsy for thyroid nodule. Genetic studies as karyotype examination for Klinefelter syndrome, 47, XXY. Genome mapping, microarray for G mutation. Immunologic studies. Investigation of antithyroid globulin A band. antithyroid peroxidase and Hashimoto's, thyroiditis, gadabfilada, CT, MRI, and others. Etiological diagnosis. Diagnosis of pituitary disease. Hormone measurements. Simultaneous measurement of H./effector pairs is necessary for assessment pituitary function. LH/FSH, E2, T. TSH, T4. ACTH, cortisol. The biorhythms of hormones, and factors that can affect their secretion such as sleep, meals, and medications, must be considered. ACTH, cortisol, GH/IGF-1, PRL. Hypothalamus pituitary hormones biorhythms. Pituitary hormones are secreted in a pulsatile manner and entrain to sleep in the circadian cycle. Recognition of these rhythms is important for endocrine testing and treatment. Diagnosis of pituitary disease. Dynamic endocrine tests. Dynamic tests involve the stimulation or suppression of H production. Dynamic tests are useful for detecting subtle endocrine dysfunction and for localizing the site of the defect. Stimulation tests are used when hypofunction is suspected and are designed to assess the reserve capacity to form and secrete H. Suppression tests are used when hyperfunction is suspected and are designed to determine whether negative feedback control is intact. Dexamethasone suppression tests. Case study 2. Anterior pituitary. ACTH. Adrenal gland. Cortisol. Target tissue. Plus 28 to 140/98 of a millimeter of mercury. PTC 8 am 520 mol/L. Ref 140/519 mol/L. Dash Dexamethasone. Dexamethasone suppression tests. Therapeutic strategies of anterior pituitary disease. Therapeutic strategies of anterior pituitary diseases. Treatment of hyperfunction. Tumor. Remove a tumor by surgery. Destroy a tumor by radiation, radiotherapy. Medication. Use chemical agents to block or inhibit the excessive biosynthesis or release of the hormone. Therapeutic strategies of anterior pituitary diseases. Treatment of hypofunction. The basic form of remedy is replacement therapy by using a hormone-defected ablation of a tumor which destroys or compresses the endocrine tissue. Hypopituitarism case study. 65, 31, 30, 10, 1, T38.5, 4, 10 kg, T36.0, P78/R16/BP 1/60 of a millimeter of mercury. 78/. Hypopituitarism definition. Major causes: mass lesions, pituitary adenomas, other benign tumors, cysts. Pituitary surgery. Pituitary radiation. Infiltrative lesions, lymphocytic hypophysitis, hemochromatosis. Infarction, Sheehan syndrome. Apoplexy. Genetic diseases. Definition: hypopituitarism refers to decreased secretion of pituitary hormones. Hypopituitarism can result from diseases of the pituitary gland or from diseases of the hypothalamus. Major causes: pituitary diseases, hypothalamic diseases, mass lesions, benign and malignant tumors, radiation, thysness and nasopharyngeal, malignancies, infiltrative lesions, Langerhans cell histiocytosis, trauma, fracture of skull, base infections, TB, meningitis, anterior pituitary infarction, Sheehan syndrome. The anterior pituitary lacks a major direct arterial blood supply. It is bathed in a dense capillary network, hypothalamic-hypophyseal portal venous system. The pituitary gland is enlarged in pregnancy and prone to infarction from hypovolemic shock. Clinical manifestations of hypopituitarism. The clinical manifestations of hypopituitarism depend on the following factors: the rapidity with which a disease affects anterior pituitary cells, the severity of the hormonal deficiency, the number of different anterior pituitary cells that are affected, leading to impairment in the secretion of one, a few, or all the pituitary hormones. Clinical manifestations of hypopituitarism ACTH deficiency. Symptoms/signs. Frequency. Percent. Weakness, tiredness, fatigue. 100. Anorexia. Gastrointestinal symptoms. 92. Nausea. 86. Vomiting. 75. Constipation. 33. Abdominal pain. 31. Diarrhea. 16. Muscle or joint pains. 6 to 13. Weight loss or weight gain. The presentation of ACTH deficiency is that of the resulting cortisol deficiency. What differences between ACTH deficiency and primary adrenal insufficiency? Salt wasting, volume contraction, hyperkalemia, hyperpigmentation, hypoglycemia, pituitary adrenal crisis. The syndrome of adrenal crisis may occur in the following situations: in a previously undiagnosed patient with pituitary of adrenal insufficiency who has been subjected to serious infection or other acute, major stress. In a patient with known pituitary or adrenal insufficiency who does not take more glucocorticoid during an infection or other major illness. Clinical and laboratory findings suggesting adrenal crisis. Nausea and vomiting with a history of weakness, tiredness, fatigue, and anorexia. Abdominal pain, so-called acute abdomen. Unexplained hypoglycemia. Unexplained fever. Hyponatremia. Clinical manifestations of hypopituitarism TSH deficiency. Similar to but sometimes milder than those of primary hypothyroidism. Common symptoms: fatigue, cold intolerance, muscle cramps, headache, weight gain. Mechanism. Symptoms. Signs: slowing of metabolic processes, fatigue and weakness, cold intolerance, dyspnea on exertion, weight gain, cognitive dysfunction, constipation, slow movement and slow speech, delayed relaxation of tendon reflexes, bradycardia, carotenemia, accumulation of matrix substances, dry skin, hoarseness, edema, coarse skin, puffy faces and loss of eyebrows, periorbital edema, enlargement of the tongue, other, decreased hearing, myalgia and paresthesia, depression, menorrhagia, arthralgia, pubertal delay, diastolic hypertension, pleural and pericardial effusions, hypothyroidism crisis, myxedema coma. Myxedema coma is defined as severe hypothyroidism leading to symptoms related to slowing of function in multiple organs. Clinical features of myxedema coma: decreased mental status, hypothermia, bradycardia, hyponatremia, hypoglycemia, hypotension, precipitating illness. Hallmarks of myxedema coma. Clinical manifestations of hypopituitarism: gonadotropin deficiency. In women, ovarian hypofunction, decreased T2 secretion, irregular periods or amenorrhea, anovulatory infertility, vaginal atrophy. After several years, breast tissue decreases, bone mineral density declines. In men, testicular hypofunction, infertility, decreased T secretion, decreased energy and libido, decreased bone mineral density. Prolactin deficiency. The only known presentation of prolactin deficiency is the inability to lactate after delivery. Clinical manifestations of hypopituitarism GH deficiency. In children, growth retardation, short stature. In adults, changes in body composition, increased fat mass with a decrease in lean body mass. Clinical features of Sheehan's syndrome. A history of postpartum hemorrhage so severe as to cause hypotension and require transfusion of multiple units of blood. In severe cases, lethargy, anorexia, weight loss, and inability to lactate developed during the first days or weeks after delivery. In less severe cases, failure of postpartum lactation and failure to resume menses in the weeks and months after delivery, and loss of sexual hair, as well as milder degrees of fatigue, anorexia, and weight loss. In mild cases, possible delay in recognition for many years after the inciting event. Eventual development of a small pituitary within a cellar of normal size, sometimes read as an empty cellar on MRI. Diagnosis of hypopituitarism. Biochemical diagnosis is made by demonstrating low levels of trophic hormones in the setting of low target hormone levels. Each pituitary hormone must be tested separately. ACTH. Basal ACTH cortisol secretion, 8 am to 9 am. ACTH reserve, stimulating test. TSH, T4. LH/FSH, E2/T, 8 am to 10 am. Basal GH, IGF-1, stimulating test. Case study labs. Final diagnosis. ACTH 8 am, 15.1 nanograms/Shell, ref. 5.0 to 78 nanograms/Shell. PTC, 84 mol/Shell, ref. 147,609 mol/Shell. TSH, 2.91 mu/Shell, ref. 0.2 to 4.5 mu/Shell. FT4, 3:40 mol/Shell, ref. 1224 mol/Shell. LH, less than 0.1 mu/Shell, ref. 7.7 to 58.8. FSH 0.487 mu/ml, ref. 1.77.7. E2, less than 5.0 pg/ml, ref. 5 to 54. GH, 0.92 nanograms/ml, ref. 0.126 to 9.88. Final diagnosis. Hypopituitarism or Sheehan syndrome. Treatment of hypopituitarism. The treatments of ACTH, TSH, and LH/FSH deficiencies are the same as the treatments of primary deficiencies of the respective target glands. Treatment regimens that mimic physiologic hormone production allow for maintenance of satisfactory clinical homeostasis. Hormone replacement therapy, including glucocorticoids, thyroid hormone, sex steroids, and growth hormone, is usually free of complications. Hormone replacement therapy. Trophic hormone deficit. Hormone replacement. ACTH. Hydrocortisone, 10 to 25 mg/d, or prednisone, 2.5 mg to 5 mg am. TSH. L-thyroxine, 75 g-150 g daily. LH/FSH. Males, testosterone undecanoate capsule, 40 to 120 mg/d. Females, estradiol, 1 mg to 2 mg QD21D, progesterone, 5 to 10 mg QD, on days 14 to 21 for fertility, Human chorionic gonadotropins. GH. Adults, somatotropin, 0.3 to 1.0 mg SCQD, children, somatotropin, 0.02 to 0.05 mg/kg/d. All doses shown should be individualized for specific patients and should be reassessed during stress, surgery, or pregnancy. The management of this patient. First and second day. Fluid therapy. Hydrocortisone 100 mg for. Third and fourth day. Hydrocortisone 50 mg for. L-thyroxine 25 grams/d po. 5 days later. Prednisone 5 mg/d po. The patient discharged 1 week later and follow up regularly at outpatient department. -1 dash. -2. Case Study 17, CT. Division of Endocrinology and Metabolism. West China Hospital, SCU. Case Study. Case Study. HPG axis, E2, 1.8 pg/ml, ref. 5 to 54, p, 0.08 nanograms/ml, ref. 0.1 to 0.8, FSH, 2.9 μ/L, ref. 1.7 to 7.7, LH, 3.4 μ/L, ref. 7.7 to 58.8. PRL, 42.8 nanograms/ml, ref. 6 to 29. HPT axis FT3, 2.1 mol/L, ref. 3.6 to 7.5, FT4, 5.2 mol/L, ref. 13 to 23, TSH, 100 μ/L, ref. 0.35.0. HPA axis PTC, 8 AM, 414 mol/L, ref. 171,536, ACF, 35 mol/L, ref. 12 to 65. GH, 1.2 nanograms/ml, ref. 0.126 to 9.88.